morning, and thank you so much for the introduction, the opportunity to be here and to learn from everyone this weekend. Just a plug for next year's weekend, or next year's meeting. The board has definitely picked out a really nice location down in Naples where I live. That resort has just been remodeled after some of the hurricanes we've had, so I think everyone would have a really great time there. So we're going to be talking about femoral neck fractures in the geriatric patient. When do you fix them? Who gets a Hemi? Who gets a total? Kind of working through that and how you manage those on call and what the data says. These are my disclosures here. More of a disclosure is that I am a fellowship-trained arthroplasty surgeon, and definitely I personally have a bias for the anterior approach, so we have an absolutely aging population, particularly where I live in Naples, and with that, the total number of hip fractures is also increasing. And half of those hip fractures are femoral neck fractures. But the patient population is very different. You may have a 70-year-old with a page long of medical comorbidities who uses a walker and doesn't leave the home independently, versus an 85-year-old who only takes a statin and plays pickleball 5 days a week. So you may manage them differently. And when we talk about femoral neck fractures, the Garden classification system is the one we typically use, with types 1 and 2 being non-displaced and types 3 and 4 being displaced. So historically, when you're considering, are you going to do an arthroplasty versus an ORIF, typically the 1s and 2s, you would do an ORIF, and the 3s and 4s, which are displaced, would undergo an arthroplasty. And the thought was, well, ORIF is less invasive, decreased blood loss, but there has been an increase in the literature looking at how do we manage these non-displaced femoral neck fractures because of the concern of the high rate of reoperation. And if you look at it, it's anywhere between 10 and 48% risk of reoperation. And specifically looking at non-displaced fractures, it's an 11 to 20% different rate of reoperation. And I would argue that doing cannulated screws or a DHS is not that different from doing a hemiarthroplasty as far as the level of invasiveness with our hypotensive anesthesia, TXA. So then if we're going to do an ORIF, there's been some data about how do we predict who's going to fail. And if you look at a lateral x-ray and there's more than 20 degrees of posterior tilt, those patients were at an increased rate for reoperation. They had a 22% risk versus an 11%. Additionally, their 80-year-old patients had a higher rate of going on to needing a subsequent arthroplasty for failure. So that moved us on to look at a multi-center trial saying, well, okay, if we're having a high rate of reoperation, what if we just take all of these hip fractures, the non-displaced and the displaced, and treat them all with an arthroplasty? And at their 1-year follow-up, they had a reoperation rate of 7% versus the 11 to 20% for the non-displaced previously that's been discussed. So if you are going to to do an arthroplasty, you should cement them. And in 2021, the AAOS updated the recommendations to say there is a strong level of evidence to cement. That being said, if you look at the AJRR data, this is from 2023, you see in 2022 that only 50% of hemiarthroplasties in the graph there in the yellow are being cemented. And if you look in the graph in the blue, our 90-year-old patients, only 52% of them were getting a cemented hemiarthroplasty for femoral neck fracture. And we know it's been shown over and over again in the literature that cemented stems reduce complications. Most of the systems are very simple these days. You don't need to ream and broach anymore. Usually you can do a broach-only system, and it really simplifies the workflow. Usually when I talk to surgeons and ask them why they aren't cementing their hip fractures, they say, well, I'm concerned about the risk of bone cement implant syndrome. And that risk, although it's catastrophic, it is really rare. It's 0.1 to 0.4%. And you can limit that risk by coordinating with anesthesia, making sure that they properly resuscitated your patient and doing a 4th generation cementing technique. Now, I trained in the time where we were press fitting all of these stems, and so if you haven't done a lot of cementing, it's very simple. Basically, if you use everything in the femoral prep kit, you've probably done it right. So put in your cement restrictor, use a brush, pulse lavage, and then use vacuum mixed cement and retrograde fill. So then we look at, well, if we're going to do an arthroplasty, we've decided who's going to get a Hemi and who's going to get a total. And in the health trial, they looked at patients at least 50 years old who ambulated independently, whether with an assistive device or not, who had a displaced femoral neck fracture. And those patients were randomized to either a Hemi or a total. And they looked at the need for a secondary surgery in 2 years. And in that, they had no difference. They did find more reductions in the total hip group versus the hemiarthroplasty group. And more implant exchanges in the hemiarthroplasty group. There was a statistically significant improvement in the hip outcome scores for total hip. However, this was not meeting the minimal clinically important difference. And in a secondary analysis, which is very interesting, they looked at their youngest, fittest patients, and they actually had no difference for Hemi or total. So usually the question that comes up is a Friday night, patient comes in with a displaced femoral neck fracture, person on call isn't really comfortable doing a total, but they are comfortable doing a Hemi. And the data shows you have patients wait, their rate of mortality goes up. Data shows there may be a very slight functional difference in a total. So I would ask yourself, what do you gain by having that patient lie in bed for an additional 3 days waiting for the joint surgeon who says they're not available on the weekend? So I would recommend then proceeding with the surgery to get them up and moving. Paper here out of the Mayo Clinic looked at, well, in modern times, why are our total hips for femoral neck fracture being revised? And they had an 8% rate of revision due to primarily periprosthetic fracture and infection. Hip instability was only 1.4% in their series. They did have a very high rate of anterolateral approach in their study. So what we know is that posterior tilt is associated with an increased risk of failure for internal fixation. So really critically evaluate your x-rays. If you're not sure, get a CT scan. And if there's any evidence of displacement, have a very low threshold to go on to an arthroplasty. So that way these patients who are already very frail and it's hard to get them maybe through even one surgery, they don't go on to needing a secondary conversion arthroplasty, because that is a much bigger surgery than doing a hemiarthroplasty. Arthroplasty is becoming more common due to the lower reoperation rates. We know cementing for hip fracture decreases the rate of complications, and a total hip may have a slight functional benefit, but also may have an elevated risk of dislocation. So there are many things you can do to help lower that risk. Consider using a high offset stem. You may lengthen them 1 or 2 millimeters. And if you can't get a 36 millimeter head, you consider using a dual mobility. And thank you for the opportunity.